Well, welcome everyone. I think we're ready to get started. To let everyone know, we've already started recording. I'm very happy to see as many students as we have here. It's very exciting to get started on the Zoom sessions for the spring semester. And we're starting today with Occupational Therapy Assistant. We would like to welcome Mr. Darnell Miller, who is the STC Program Chair for the Occupational Therapy Assistant Program. Mr. Miller, I'm going to turn the session over to you.
Okay, well, good morning, everybody. My name is Darnell Miller. As Ms. Claudia said, I am the Program Chair of the Occupational Therapy Assistant Program here at South Texas College. I currently work as a COTA, which is a Certified Occupational Therapy Assistant. I have been one for about 32 years now. I really enjoy what I do. Excuse me real quick. There's some other people joining us here in my office. Okay. My role basically right now is I am a faculty and program chair. So what I do is train the next generation of therapists that will be coming into the profession of occupational therapy. And hopefully one day I'll get to see you in our classroom to be able to train you as a new OT practitioner, OT assistant, and hopefully you can go on to get your occupational therapy degree, your master's, and then your doctorate. What I'm going to do now is transfer you over to my PowerPoint. If you give me a minute to kind of get things set up, and I'll go through the PowerPoint and explaining what occupational therapy is, and also the qualifications to be either an occupational therapist or an occupational therapy assistant. So give me 1 second, please.
Mr. Miller, really quickly, if you want to share with the kids, what got you into wanting to be an occupational therapist? What's your background? Tell us a little bit about yourself.
My path is very different than most people. I went to college for engineering at first, and realized I didn't want that. I didn't know what I wanted to do, but I knew I liked exercise and anything with anatomy, athletics. That's my background. I was looking at physical therapy and found out I just didn't have the time to get into that. So I kind of chose occupational therapy as a career. I joined the military actually to get my training. I had no money for college because I used it all up financial aid, attending college the first time. So I joined the Army. I spent 6 years active duty military, stationed either at Fort Sam Houston, where I got in San Antonio for my training. Then I trained at Fort Riley, Kansas, and home of the Big Red One, as we say over there.
Oh, wow.
So that's my background in occupational therapy. I got out, moved down to the Valley, and I've been practicing ever since. I've practiced in the areas of, in the military, I did a lot of mental health for our soldiers. I also did a lot of triage, which is like gunshot wound care, burns, and things like that, because it is the military. It's a very rewarding experience, but we also saw the retired military, the children of soldiers and their families, so we saw those also. Getting out of the military, I moved to the Valley, and I immediately got into outpatient therapy. So I was doing hand therapy, basic orthopedics, then I went to the hospitals, nursing homes, school systems, pediatric clinics, pretty much the whole gamut of what occupational therapy is. Before I became an instructor here, I worked at Life Care Center, Life Care Hospital, where it's a long-term acute care center. And I really liked working there. Out of all the jobs, I think, beyond the military, that was my favorite job that I had.
So you had a lot of different options as to where you could go with occupational therapy, it seems like.
Yes, there is. Basically, we say occupational therapy works from a person's from birth to death and all points in between. So as you see in my video, we're working hospitals and neonatal units, and we also can work in hospice. We work in hospitals, pediatric clinics, inpatient, outpatient, school systems. We also do community work also. So you see occupational therapists actually working in community centers, not so much down here, but in the bigger cities, you'll see us there also. So occupational therapy is one of those careers where if you have a great idea, you like to help people, you can pretty much do anything you want to do in occupational therapy. So
wow, that sounds great. Well, I'm excited to see your PowerPoint, and we're glad that we got to know a little bit about you, and you seem pretty awesome.
Thank you. So let me transfer over real quick. Give me a minute.
While you're transferring, I'm going to remind the students and the teachers that if you have questions, open up the chat feature and put your questions there, and we'll ask Mr. Miller those questions as we go along.
In this
And
one?
that one.
Yeah.
Okay.
And then share
Share screen on there.
down there. There you go. And then just hit share. There you go.
Okay, so like I said, this is occupational therapy. My name is Darnell Miller, so I'll go through my slideshow. If you have any questions, feel free to ask as we go through this. So basically, occupational therapy, we all tend to think of occupational therapy, most people think of occupations as of employment. But that's not what we do in occupational therapy. We view occupation as those things you do on a daily basis. For example, if you attend school, your occupation would be a student. So we look at all those skills and all those tasks that it requires you to act in the role of a student. For instance, if you have a visual impairment or a hearing deficit, the occupational therapy will work with you and your instructor or your teacher to devise ways, techniques, and any modifications, adaptations for you to be successful in the classroom. And if we look at occupations of what people do on a daily basis, for instance, if you're a child, your occupation is play. If you're an adult or a senior, your occupation might be more leisure, or I'm going to transition into retirement. So your occupation at that point would be, well, the retirement mode. So occupations are not jobs, but they can incorporate jobs if you're having trouble at your job. But it's those things you do on a daily basis, those things are roles that you have to assume it throughout your life. And that's what occupation is, and that's what occupational therapists address. So what we do basically, we help individuals to be successful in the things they do, they want to do, they need to do, or they have to do. So those are the three big key words we look at is want tos, need tos, and have to dos. If you can look at the pictures that I have here, as you see on the top left-hand side, the children, their occupation is play. So we want to make sure that children can play successfully. If there's a deficit or something that's hindering them from playing, occupational therapists will come in and address that, whatever that deficit is. In the lower left-hand corner, there's an elderly lady with a magnifying glass, and there's an OT sitting there helping her to see what she needs to see. So we adapt the environment for her. We enlarge the print. We may give her different techniques or devices so she can see what she's doing. So if you look at all the different pictures here, and the one in the middle is with the soldier, so you'll see him making a splint on the hand. There's somebody with a prosthetic. We'll teach them to engage, use the prosthetics so they can, again, do those things they need to do on a normal basis. One thing about our soldiers is now you see guys that are active duty in the military with prosthetics. Before, you never saw that before. But because of things like occupational therapy and physical therapy and other therapies, soldiers are allowed back into active duty roles. And some even go back into combat with prosthetics because they have the training and know how to use the devices successfully. I want to show you now just a quick video of where do we work, because we work in a lot of different venues. So I'm hoping this works here. Give it a minute.
Occupational therapists enable people to do what they want and need to do in their daily lives. Occupational therapists, or OTs, work in a variety of settings with people of all ages and abilities. But people often ask what that means. Here are a few stories to help explain.
I'm an OT at a children's hospital. Baby Carly was born earlier than expected. She needed a lot of needle pokes and tests, and she had trouble feeding.
I'm Carly's mom. The OT coached me on how to walk Carly so that the injections are less painful for her. She also designed a special bottle for Carly to drink from so that she can eat safely and get the nutrition she needs to grow.
I'm an occupational therapist who works in schools. Matilda was having a hard time sitting still and listening to her teacher.
The OT worked with my teacher to make a schedule and pictures for me. He gave me a purple bouncy chair to let me work off all my extra energy. Now I know what to expect on my school day, and I can pay better attention in class.
I'm an OT working in the community. Jacob has a mental illness and was having a hard time finding and keeping the job that he liked.
The OT and I talked about the challenges I was facing. He showed me ways I could manage my time and stress levels and coached me on how to focus on my strengths. We worked together on job applications until I found something that's the perfect fit for me.
I'm an occupational therapist who works in spinal cord injury rehabilitation. Today, I'm seeing John.
After my injury, I didn't think I'd be able to access my community. The OT helped me choose the perfect wheelchair, adapted my car, and taught me skills to get where I need to go. Now I can meet up with my buddies wherever they are.
I'm an OT working in the general hospital. After her injury, the girl wasn't able to take care of herself, so she could go home.
The occupational therapist taught me about ways to be safe at home and still live a healthy and active life. She also provided me with equipment so that I could bathe and put on my fanciest clothing on my own. I'm an OT working in a long-term care facility. Walter wants to take a special someone out for dinner, but first he has to plan the date.
Even though my memory isn't what it used to be in the old days, the OT showed me how to keep a calendar to help me remember. Now I don't miss meals or activities, and I think I'm going to call that special someone next week.
Occupational therapy.
Mr. Miller, it looks like we're having some trouble with the sound in the video. Do you think we could go to the next slide?
Mr. Miller, although
Yes.
you're seeing it on your screen, we're not seeing it on ours. So if you could send me the link, I'll include it with the recording link.
Okay, no problem.
Okay, great.
Hold on a second. And now escape.
I'm sorry about that. And exit it here, right?
Yeah, that's okay.
Give me 1 second.
And you're still
No
sharing
problem.
the screen. So go back to your PowerPoint if you got more slides
Mm-hmm.
and start it right there. Okay, there you go. And now just click to your slide where you were at.
Okay. And I was where? This is the beginning, right?
Yeah.
So I'll go back. Okay. Sorry about that if you didn't see the video. First time using it. In occupational therapy, there are two different career paths. There's the OTR and there's a COTA. The OTR, or the occupational therapists as we call them, are responsible for all aspects of occupational therapy service delivery and are accountable for the safety and effectiveness of the OT service delivery process. This is a master's degree level program that UTRGV actually has there. The COTA basically is the Certified Occupational Therapy Assistant. They work under the supervision of an OTR, of the OT practitioner. What their role basically is the implementation of all of the interventions that the OTR recommends. So basically there will be a treatment plan, there will be an evaluation. The OTR will create a treatment plan and the COTA or the assistant will carry out the treatment plan. It is not where one person is higher than the other in the career path. It's basically they work in collaboration for the good of the patient. So a lot of times you'll see clinics where you see a lot of COTAs and maybe one OTR because the OTR maybe just does the evaluation and the COTA carries out all the treatment. When it comes to our time for, like say, modification of the treatment plan or discharging planning, both the OTR and the COTA actually come together with the patient and collaborate on where do we go from here? What's the process that we're going to use? Or if the person is going home, what's the best way to get that person home successfully? So those are the two roles that are there. As far as the educational process for each, the OTR, again, requires a master's degree. First, you have to get a bachelor's degree in any discipline you like. Then you'll go for a master's program. A master's program is basically 2.5 to 3 years in length beyond your bachelor's degree. Once you finish your coursework, you're required to do a 6-month internship. We call them rotations. So you do 3-month rotation maybe in an outpatient clinic or a nursing home. Another 3-month rotation might be in a pediatric clinic. But you have to satisfy 6 months of an internship. For the OT assistant position, the educational requirements are an associate's degree, which is a 2-year degree, which we offer here at South Texas College. It's 1.5 years of education, and the last semester is actually fulfilled in a fieldwork experience or an internship experience. There are 2 8-week rotations. Once you're done with your rotations, you sit for a national examination. If you pass that national examination, you're ready to work as a OT assistant.
Mr. Miller, is there a big difference in pay between a COTA and occupational therapist assistant? And if so,
go ahead. I'm sorry.
And if so, does experience also count in the pay of the occupational therapist or the location where they work? Is there some places that, you were saying that you worked in different places. Do some places naturally pay more, or what can you tell us a little bit about that?
Okay, that's actually my next slide, which is salary. Okay, according to salary.com, which is based on, again, the state of Texas, local for this region right here, an OTR, which is a master's degree, starts about $72,000 a year, $72,500 a year. Based on experience, that number will go up. And again, based on where you work, it also goes up. So if a lot of therapists work as contract therapists, which means they kind of work independently and contract themselves to different agencies, well, that salary is going to be a little bit higher, but on the downside of it is you don't get the benefits of being a full-time employee. So you might see more pay, but realizing, well, I work for myself, so I'm responsible for my own taxes, retirement, and things like that. For COTAs, which is the assistant, the average starting pay down here is about $48,000 to $49,000 a year, and that's on a full-time basis. Again, a COTA has the option to work as a contract therapist, and they will make more. Normally, what we're seeing right now is pay kind of shifts, sometimes working in skilled nursing facilities, which is long-term care or nursing homes, pays more. Sometimes pediatric pays more. Right now, pediatrics is paying a little bit more than skilled nursing, but after a while, it kind of levels out. So it all depends. Also, different parts of the state pay differently also. If you go to a major city like Houston, you might make more money, but then again, the cost of living is a little bit higher in Houston and Dallas and San Antonio than it is here in the Valley. So the pay is adjusted accordingly because of that. Any other questions on that? That's a good question. Okay. Our program here, this is an occupational therapy program here at South Texas College. We're a 2-year selective admission program. What selective admission means is you can declare the major of occupational therapy, but just because you declare that major doesn't automatically put you in the program. We have a selective admissions, which is based on a point system. So a lot of people take our intro to OT. They'll take all their prerequisites. They'll do all the different things they need to do to enter in the program. And at the summertime, the advisory committee for our program and the faculty and staff actually get together, look over all the applications, and we'll pick the top 18 to 20 students based on a point system for our program. We're a full-time program, meaning that we meet Monday through Friday from about 9 to 4. Our students are here pretty much way beyond that also because it's easy to do all your classwork here. We have all our resources here, which is our library. We have our CLE. We require 4 hours per week of mandatory CLE time or tutoring. On top of every 2 to 3 weeks, we will meet with our student success specialists. We really want our students to be successful, so we put all these resources in place so we can catch students who might be falling through the cracks. So we don't want anybody to fall through and fail the program. So we have a lot of checks and balances in our system.
And Mr. Miller, is there a waiting list for the program? Is there a certain amount of spots? So if somebody's interested in doing that, is it a fairly competitive program?
It is a very competitive program. Like I say, we are selective admissions, so what that means, it is a competitive type program. So if we have 20 slots, we might have 35 to 40 people applying for 20 slots. And so we'll pick the top 20. We also pick alternates just in case one of those members that are selected doesn't want to accept the slot, then we'll pull an alternate up into that position to accept that spot. Our GPA requirement for basic is a 3.0. So what that means basically is in all your core courses, which are your prerequisite courses, you need to have a B or better. A lot of our students that we accept into our program usually have a GPA of like 3.75 and above. So that's how competitive it is. So if you're really looking at a program, that means all your English and your anatomy and courses like that, we really look at those scores. We want the grades to be as high as possible.
And how many slots do you have per semester?
We are actually a yearly program. So we admit a class every year. They're a cohort. So what that means is if 18 start, 18 will also finish together in 2 years. So it's not a every semester kind of thing. It's just a cohort. Yeah, you start together, you finish together 2 years later. And we only accept during August. So we started the fall semester. We have an ACT requirement also. ACT score is 19 or higher to apply. So that's something we really want students to really pay attention to and really prepare for is the ACT. The prerequisites, we just have 6 prerequisites for our program. It's biology 2401, English 1301, psychology 2314, speech 1318, humanities elective, but we only allow 4, which is intro to humanities, intro to logic, intro to ethics, and the humanities course. We also have OTHA 1305, which is the introduction to occupational therapy. And what that course basically is, it introduces you to what the field of occupational therapy is, our history, what we do as a profession, the supervisory process. It really gives you a good broad scope of what occupational therapy is. And we really like that course. And the students, when they take that course, they find that they really like the profession of OT. So it's a project-based, so you do a lot of projects, but in those projects you learn about the profession of OT and what we do. And at that point, I am done with my PowerPoint. Are there any other questions? Thank you for your questions so far.
If any of the school districts have any questions, please go ahead and send them through the chat feature. I know that I have some questions.
Go ahead.
When somebody is considering the occupational therapy program and also the physical therapy program, can you tell me a little bit about what sets occupational therapy aside from physical therapy?
Well, that's a great question. Occupation, as we get that question a lot. Occupational therapy and physical therapy work collaboratively hand in hand in patient care. Occupational therapy looks at the person from a very holistic point of view. Physical therapy is maybe more of a biomechanical point of view. So what that means is, let's say, I'll give an example. Let's say somebody breaks their hip. Physical therapy will spend a lot of time making sure they can develop the strength to walk again, to be able to, we call it ambulation or gait. OT, we look at the same thing, but we're also going to look at that individual ability to maybe dress themselves or transfer to the toilet and do toileting skills, maybe to also be able to fulfill the role of, let's say, they have to cook. And so can they, on that broken hip, get up and use assistive devices, adaptive devices, and cook? Okay, so we're going to show them all those precautionary techniques. PT does that too. But we look at that in the performance of their everyday tasks, which is their occupations again. Well, that's the term occupational therapy. So we will make sure they can do all those skills they need to do, even with that injury.
And we got a question from La Jolla Academy for Health Science. They'd like to know, what type of specific treatments do you do for elderly in long-term care facilities?
That's a good question. That's a large question because there's so much. Again, that depends on what that client needs. So let's say they're going to go to a long-term care facility from a hospital. So basically what an OT would do is basically, again, look at as far as strengthening and coordination, on top of dressing skills, on top of, okay, what do you do at home? Let's address those skills you do at home. If an individual is long-term at a nursing home, meaning that's where they live, we don't make sure we give them a good quality of life where they live. So not only physically, but make sure they're engaged and they're able to engage in maybe the activities that they do from the activities department. They can still get in there and participate in the bathing process where they're not a total assist, where somebody's helping them do everything, that they can also help themselves at the same time. So there's a lot that's entailed in that kind of question. And again, it depends on what that client needs is what an OT would work on with that individual.
And Mr. Miller, I know we have just a couple minutes left in your session. What would you say to someone that's considering occupational therapy? What has been your experience, and what are some of the rewarding features to this career?
For somebody that wants to get into it, I always say, it's not a job, it's a career. And like I say, OT is more of we like to say it's a vocation. You find yourself drawn to it based on the things that, that you see, but also a lot of it comes out of you. We have a term that we use called therapeutic use of self. It's where you're able to empathize with that individual and also put yourself into that treatment session, because of all the things you do with an individual, you being there and you putting your 100% of your personality, of your being into that treatment is really what makes the person respond a lot better. You can have two therapists sitting side by side doing the same exact thing. Then one therapist might be, let's say they're sitting on their phone and doing their other stuff while they're trying to treat the patient, where you have another therapist just fully engaged with that client, talking to them, really giving all their being to that person. And that person will actually get better quicker than the other person. It's more mechanical type process. I've been doing this for 32 years. I love what I do. Okay? You can't do a job for 32 years and not really love what you do. So it's a great profession. I don't know what else to say. If you want to come talk to us here, feel free. On one of the slides here, we have our contact information. But truly, this is a great career. If you find that you're interested, just give us a call.
Thank you so much, Mr. Miller. And it looks like I have one more question. Let's see. What are the most important skills, and this will be my last question, what are the most important skills to have to make a great COTA?
Wow, that's a good question also. You have to be willing to learn. You have to be willing to, this is a great question because actually it's one of my homework assignments for my students, to be able to accept criticism and learn from it constructively. You have to be somebody that's self-motivated, have initiation. You have to be a self-learner, because in our profession, even though you graduate from the program, you are always learning. You are always improving your skills. You have to have great communication skills, because we talk on a daily basis. A lot of what we do is we educate clients. So we have to have a great skill of the vocabulary of occupational therapy. Again, that therapeutic use of self is something that's tremendous that we need to have also. But there's a longer list than that, but I know we're short on time.
Thank you so much, Mr. Miller. And right now I'm going to, I guess, pass it to Claudia, who's going to be introducing our DHR representative, and we're going to have her talk a little bit about on-site occupational therapy at the hospital. I'm going to ask everybody to please make sure you're on mute so we can hear everything clearly, and we'll recap in about 25 minutes after we're almost through with the hospital presentation. So go ahead, Claudia.
Thank you, Dr. Alvarado, and thank you, Mr. Miller. That was a great presentation. I've learned so much, not being in the medical field, about occupational therapy and being an occupational therapy assistant. I want to introduce Jessica Salinas. Jessica Salinas is the Director of Student Services at DHR, and she'll be talking with us over the next part of the Zoom session. Again, if you have any questions, put them in the Zoom chat and we'll relay them to her. So Jessica, welcome, and the stage is yours.
Hi, thank you so much. Well, welcome everyone. It's nice to see everyone again, even if it is. So I just gave away my surprise. We're actually at our rehab hospital, which is one of our facilities at Doctors Hospital. And we are going to showcase one of our instruments, one of our pieces of equipment, and we're also going to hear from the director, Dr. Michael Auer, who also runs this facility and most importantly, works with our patients one-on-one. So what you're seeing now is our lobby area. And that's Jose right there, who welcomes all our patients. We also have a little waiting area for our patients and their families when they want to visit and spend some time in the hospital. And then, of course, we have our conference room where we also have additional trainings where folks from both the community and our internal community come and provide different services. So on that note, we are waiting for Dr. Michael Auer, who's going to give us a little show of one of the most renowned pieces of equipment that Doctors Hospital has and that works on patients' lives. So what you just heard from the school side, from STC, is what are the steps to getting to where we're at now. This is the actual practice of occupational therapy and really making patients' lives better, enhancing the way that they walk every day. So we are hanging tight. Give me a couple of seconds. So let me share a little bit about what's going on today at our hospital while we're running a little late. Our hospital, like many other hospitals, of course, you guys know that we service patients, right? So what happens when patients don't feel well? They end up coming to us. What's happening this week is what we call we've met census and we've surpassed census. And we have a waiting list. So what does this mean? What this means for Dr. Michael Auer, who will be here in a minute, is that he decides directing and running this facility. He has now had to put on his scrubs. You're going to see him in scrubs, although he's normally in a tie and running around in meetings. He's had to actually jump in and help his team service patients. Why? Because we have folks that need help, and he's not only trained in administration, but he's a doctor in OT. So that's real important for us at Doctors Hospital, is that we're able to take off our suits and jump right back in and help the team out. And on that note, I just saw him from the corner of my eye. I want to take a minute to introduce Dr. Michael Auer. And I would like you guys to spend some time and look at this guy, because he is one of my go-to guys. And what I mean by that is that he's always willing to teach everyone in the community, including you on cyber mentoring, that what is important about OT. So he takes time out of his daily schedule, last minute calls, 3 weeks in advance to talk to you. So on this note, this is Dr. Michael Auer. Thank you, Dr. Auer, for joining us. As I shared, you can see he's in scrubs. This is not his norm. He's normally all tidy in his suit, but he's jumped in to help his team again. Why? Because patients need him and they need us. So on that note, I'll let Dr. Auer come in.
Absolutely. Are you going here for a little bit?
Sure.
Okay, come on this way. That way we can talk a little bit.
Go ahead.
All right. It's a little quieter in here. So like Ms. Lena said, my name is Dr. Michael Auer. I'm a physical therapist. I've been in the field of therapy for about 17 years. I started as a physical therapist assistant, went back to school and got my doctorate for physical therapy. I attended St. Philip's College in San Antonio. I attended St. Mary's University, and I finished my doctorate at University of Texas Health Science Center, San Antonio. I specialize in treating patients with disorders, spinal cord, and amputee. My background has been pretty much all inpatient rehab. That is my passion. That is my love. I have recently, in the past almost 2 years, converted into this administrative role, which was hard because I love the clinic, but to further our programs here, to grow, to become the best in the RGV, and hopefully, not hopefully, we will become one of the most competitive rehab facilities in the state and nation. That is our goal. That is what we are striving for. A little bit about rehab. We are CARF accredited, so that stands for the Commission of Rehabilitation, Accreditation Rehabilitation Centers. So we have that accolade. We are the only CARF accredited facility with a specialty for stroke. We're the only one that has that accreditation for stroke in the whole Rio Grande Valley. We have 2 support groups that we have. We have the amputee support group, which is the first Wednesday of every month, and we have the stroke support group the 3rd Thursday of every month. And a little bit later, I'll show you about the robotic exoskeleton by the company Exo. We have 2 of those robotic exoskeletons, and we're the only facility south of San Antonio and Houston to have those. And I'll talk a little bit more about that coming up. But I hear this is exclusively about occupational therapy, and so I can talk to that. My wife is an occupational therapist. She specializes in cerebral palsy and autism, and she's worked at several facilities here and in San Antonio as well. PT and OT and speech, they have to work closely together if we're going to optimize our outcomes with our patient. There's a lot of overlap with the speech and OT. There's a lot of overlap in reference to cognition. We have to tap into that with our neurological patients, especially to really optimize our outcomes. With PT and OT, we have to really overlap in reference to trunk stabilization, trunk mobility. So PT can propel upon that to further their gait training, their balance, and OT takes that overlap at the trunk in reference to getting the patient to operate outside their base of support with their upper extremity limbs and performing activities of daily living. Two of the things that I have noticed from the other side of the therapy spectrum from PT that I think OT really shines on is sensory integration. They seem to have, OTs seem to have a very good concept of how important the sensory system is. And therapists that specialize in neurological disorders, they do too, but I've seen most that I've met, sensory is just so important to consider when you're treating the neurological patient. In reference to the brain, I don't know how far y'all went into that yet or where you are in your curriculum, but in reference to the brain, the sensory centers are on the post-central gyrus of the brain, Brodmann's area S1 and S2. And so when we touch somebody, that sensation goes up through the peripheral nerves to the spinal cord, up a one-way track to the brain and to that sensory center S1, S2. On the way up, it drops information off at the cerebellum. It goes to S1, S2, shoots that information up to the front of the brain, the motor centers, premotor, supplementary motor, and motor 1, Brodmann's area motor 1. And then it takes all that information, processes it, and executes the movement. So if I touch something hot, I either know to take my hand away very quickly, or if I guard it, if somebody touched my hand. Taking that to the neurologic patient and how we process things, you know, we have to reorganize the brain when there's insult to neurological disorders, and OTs really shine at that. So,
Dr. R, I have a quick question that came in. I know that Jessica mentioned that you're in the hospital rehab facility. Can you tell us a little bit about how many occupational therapists you have on any given day, how many physical therapists, and how you choose what patient goes with an occupational therapist or goes with the physical therapist, and most importantly, with occupational therapists, when you interview them or when you're looking at them as a candidate, what is it that you look for? What do the students need to start working on now in order to prepare for that?
Excellent. Thank you for the guidance, because I will go off on tangents about specifics. Okay, so in reference to that, here we have 9 occupational therapists. All our therapy licensed staff is an occupational therapist. We don't have any CODAs. When we first opened this facility, when I was here, we had CODAs, but over the course of time, we started just for some reason accruing more occupational therapists. One of our most senior therapists is an occupational therapist, but she started as a CODA. So here at rehab, our turnover is extremely low. So people that start here, they stay here. Even when they go and finish their education or advance their education, they come back. They like it here. So in the rehab setting, we have 9. In reference to who gets OT, who gets PT, to be into the inpatient rehab facility, they have to be able to tolerate 3 hours of therapy a day. Mandatory, at least 3 hours of therapy a day. They have to have a necessary of nursing involvement. They have to have something that nursing has to be able to manage: antibiotics, bowel and bladder program, IV medications, or anything of that order. They have to require that to come into inpatient rehab. On top of that, you have to have one of the 13 qualifying diagnoses, but for the most part, it's all neurological based. And that goes into a 60-40 rule, but I could go on a tangent on that as well. OTs, go ahead, you had a question?
Yes, how are their schedules? Do they work like nurses, where nurses work a 24-hour shift, or do occupational therapists have a 9 to 5, or how do you guys determine that?
That is unique. All centers vary, but here we have pretty much, we start at around 8 Some OTs start at 7:30 because they assist the patients in the dining room in reference to feeding. So we have an OT table that I can take you by, and I can show that to you later, where we have a table for OT and a table for speech. And at the OT table, they assist patients that have problem bringing food to mouth. At the speech table, they help patients that have problems with swallowing. So they've already passed an MBSS, but they need a speech therapist there to kind of help them with strategies for the swallow. So we have those two tables there, so they can start their day at as early as 7:30. For the most part, I'm very proud to say that our ratios for therapy for OT and PT is 4-to-1. So they see 4 patients to every 1 therapist. Each therapist sees a patient for about an hour and a half. If we have extra time, we see them a little more. So our stroke patients, not only do they get an hour and a half of OT, they get an hour and a half of PT, but they also get an hour with speech. So that minimum requirement here at DHR for our stroke patients, they get 4 hours. They don't get the minimum 3. So that's how our day is structured in reference to that. Sometimes our day goes a little longer. Say a family is present and they have questions at the end of the day when they start trickling in around 4 or 5 when they get out of work. We don't just say, my day ends at 5, I gotta go home. If the family has questions and they call for OT, or the OT's walking out the door and they recognize them, we stay, we educate them. We take that opportunity, because education is very integral for the recovery of these patients. So we educate. We also OTs do home evals. They'll go to the patient's home if the doctor requests it. And so we'll take the patient with us. We'll examine their home, their doorways. If there's any modifications that need to be done, the OT will make recommendations for widening the doorways, a ramp, grab bars, certain toilets, raising the bed, lowering the bed, taking up the rugs, things like that that are going to make the home safer. And we take that, we bring that information back, we make a report, and we give it to the family so they have something tangible to make those modifications at home. And then our case managers get involved, and they give them a list of people who can make those modifications for them. So we don't just say, this is what you need to do, good luck. We give them every piece of information to be successful in modifying that home for their loved one or the patient themselves for when they go home. So that's what we do here in reference to OT. Did I miss anything? Any other your questions?
No, I don't think so. If any of the school districts have any questions, please use the chat feature. Dr. Auer, I don't know if you want to take this time to kind of walk us around or show us any area that we haven't seen. I know that with Mr. Miller, we talked a lot about the difference between PT and OT, and the difference in the education levels of a PT and OT therapist. But I guess since we're talking about these types of career fields, I would be interested in knowing why you got interested in this particular field. Is there something that differentiates therapists from, let's say, nurses or doctors or any other type of healthcare professionals? I know that Mr. Miller shared his story a little bit with us. Can you tell us a little bit about why you were interested in therapy?
Yeah, absolutely. Well, everybody has a different reason or their calling to therapy. My calling started at maybe around 7 years old. My father is a T10 complete paraplegic. He's been that way since he was 19 years old. So that means that he's paralyzed from the belly button down. He can't feel, he can't move his legs at all. He got that accident in a car accident, racing on the street. So your typical 19-year-old risk taker male, that is your demographic for spinal cord injury. That was my father. And so he went through a intensive bout of rehabilitation. And so I guess when I was old enough to ask the question, where did you learn to do all these things? Because he used to play wheelchair basketball. He drives a car still. He goes to work. He does everything on his own. He's independent with everything. And I asked him, I said, where'd you learn how to do all these things? And he said, my physical therapist taught me. And I said, that's what I want to do. And so that's what inspired me to do that. So I do have an extra infinity of love for spinal cord patients. And so that's what started my career path off. You know, I took a little bit of the longer route because I went to PTA first. You know, we all have, you know, life experiences that help us, but I think it helped create me to be a better therapist because the early part of my career, I got to focus just on the treatment. I didn't have to worry about the evaluations and things like that. I just focused on the treatment. I got my evaluation from my physical therapist, and I was able to be in an environment in San Antonio when my career started, and in Houston to have good mentors. Mentors are important. I encourage you when you graduate, don't just go after the money, go for a place where you are going to be able to learn, and you got people that have been there for years, that have certifications, that have experiences to teach you, because that is going to be able to give you a better base of knowledge and to make you more competitive in the future. But
Dr. R, the money's good though, right?
For in reference to into the profession,
yes.
Yeah. I can say I've worked in Houston, I've worked in San Antonio, I've worked here, and I've worked for the military as well. The Valley pays very well, very, very well. The profession pays very, very well. But the Valley in particular is one of the highest paid areas in not only in Texas, it is the highest paid area in Texas, but it's one of the highest paid areas in the nation. So yeah, it pays very well. It's you know, it comes in waves. Like in 1997 during the Balanced Budget Act, you know, there was a big you know, shortage of therapists because there was, you know, some things going on, and it came back. And then so in the early 2000s, it paid really well in the Valley. And then, you know, it started kind of going down a little bit. Now it's kind of like leveling off again. But all in all, yeah, it pays very well.
We have a question from La Jolla. If somebody is interested in robotics, is there a place for them in the COTA career?
COTA career, I would say yes. It depends on the facility where you work at. Certain facilities, like flagship facilities, they have specialty programs in robotics, and they'll have the equipment for you to utilize robotics. Like the Rio and EXO is having some things come out. Bioness has some things coming out. There's a lot of virtual reality things that are coming out in reference to these things. So, you know, if you're a coder that wants to get into robotics, you have to inform yourself about what's out there in robotics. And when you're looking for a facility, look for a facility that have those pieces of equipment, because that's how you're going to have access to robotics. Currently, we do not have anything in reference to robotics for the upper extremity yet, but that's in our future. We only have things in reference to robotics for the leg. Now, there are flagship facilities where they have a robotics department, like Texas Institute of Rehabilitation and Research in Houston. I used to work there in the early part of my career. They have a robotics department. We have 2 exoskeletons, they have 13.
Wow.
The Shirley Ryan Ability Lab, formerly known as the Rehab Institute of Chicago, is ranked #1 in the nation for rehabilitation for the past 26 years. They have a huge robotics department.
And what's an exoskeleton?
An exoskeleton is a type of robot that attaches to the patient's body and is just that. It's an external skeleton that facilitates movement.
Oh,
and
wow.
All different degrees of exoskeletons, which we'll go show you in a second. You know, Honda makes one, Hyundai makes one, Toyota makes one.
Wow.
There's the Rex, the Indigo, the Rewalk, the EXO. We went with EXO, EKSO, because when doing my research, it was the preferred exoskeleton of choice for the rehabilitation setting. The Rewalk and the Indigo are more for rehabilitation, but also for at home. So there's not a lot of parameters and modifications that we can make to really optimize the patient's rehabilitation experience when using exoskeletons. EXO has those. So EXO, it weighs about 45 pounds. It can accommodate patients from 5 feet tall to 6'2", up to 220 pounds. It's the only exoskeleton FDA approved for spinal cord and stroke. A lot of literature coming out on these things. There was the International Robotics Symposium that was recently held in Houston last year. in 2017 at the later part of the year. And then also there was the users convention for EXO that was out in Austin. And I attended that one. And so out of the whole nation, they chose Austin, Texas, because Texas is taking a very proactive role in robotics. So there's a lot of facilities, including us, and the northern part of Texas that are really, really getting into robotics. And we're getting into robotics on the way up. And so that's where we are in robotics.
Perfect. So if any of the other school districts have questions, send them through the chat feature. We have about 10 minutes, Dr. Auer, so I don't know if you guys want to show us anything or what you guys would like us to do.
Sure, let's go show you the robot. Follow me.
Go ahead.
Can you believe that?
Okay, right this way.
There we go.
Okay, how you doing? This is Nathan. He's a doctor of physical therapy. This is Abraham, occupational therapist. So here also at DHR, we work in pairs. So Nathan and Abraham are the OT, PT combo, and they see all the same patients together. And so that is so we can enhance collaboration, we can continuity of care and things of that nature. The patient here, Victoria, had a stroke, a CVA, and she's getting the exoskeleton. So as they're suiting her up, they're going to be bringing her to standing, and then you can see how they utilize the exoskeleton. So the exoskeleton, there's a couple of features that it has where it'll bring the patient up to standing by the push of a button. The patient doesn't have to do anything. After the patient is up, we can choose a few settings. One setting is called first step. So first step will allow the therapist to be in control of every step. So we push a button and it'll move the patient's limb for them. That is good to enhance neuroplasticity. We can get high repetitions with good quality movement. The exoskeleton keeps the patient in proper body alignment during a functional task with high repetitions. So in terms of neuroplasticity, those are three very important objectives. Make it functional, proper body alignment, high repetitions. Those three things is a very important recipe for good outcomes. And EXO does that. But you can apply that concept to any intervention, right? It also has a setting called ProStep Plus, which once the patient's up for walk, it will allow the patient to do as much as they can on their own, and whatever they cannot do, EXO will do the rest. It has that smart feature to be able to allow the patient to actively participate in it. We also have a feature called Free, where we will put the legs in free, so the patient will be totally on their own in advancing their leg, but there'll be safety features in there that won't let the patient buckle.
And there'll be therapists there with them also, right? To make sure.
Always. You have to be a physical therapist to operate this device, a licensed physical therapist, and they have to go to a 4-week certification. We have 2 robotic exoskeletons, and we have 8 certified therapists here at Doctors Hospital Renaissance. So the physical therapist always has to be present. A tech is present, or even a physical therapist assistant can be present. And so usually the physical therapist or the PTA could do handling, or one man the controller. And then we can change the settings as we go through the utilization of the device. What you need, Nathan? Okay. So we're just waiting for the tech, and then we're gonna get up and get moving. Is there any questions from the students or anything?
Let me check. Dr. R, how much does this equipment cost?
Well, it varies. It's in the six-figure range for one. We've got a good deal because we have upper administration that are businessmen and they know how to negotiate. But yeah, we got a deal on both of these exoskeletons. There are new features that come out where that EMG is added to this device. And so it'll do electrical stimulation while it's being utilized. It operates, the backpack has a computer system, so any updates or anything of that nature, it'll be updated just like you would do Windows or something on your Apple computer. It'll be remotely. It operates off of lithium ion batteries, 2 of them, and they can last up to 8 hours, but it also depends on how long they last in reference to how much the exoskeleton is helping the person. So if it's helping the person more, the batteries will diminish faster. So the good thing that I've seen about this device is that we can get low-level patients up much sooner to ambulate. And when I would normally get them in the bars and it would take 2 or 3 people to walk somebody in the bars 20 feet, I could take that same patient with 2 people and walk them 100 feet. And so what that does to the patient's muscles, to their neuroplasticity, to their motivation, to the psychological aspect to them, they feel more active, they're upright. Being upright alone increases awareness and arousal by stimulating the reticular formation of the brain. All these things help with digestion. So being upright helps, move, your bowels so you can get your digestive system back in order. Multiple factors that being upright and utilizing this device that it helps. And so we're about to get started right here. You ready, Victoria?
Turn the wagon around.
This patient right here, she has what we call a little bit of neglect. That's why she's wearing the eye patch, so we can orient her more towards her left side. Also, she experiences some type of diplopia, double vision, so we're using the eye patch for that reason also. Our experience with dealing with patients that have neglect or even Usher syndrome, EXO, because it keeps them in midline and helps them orient, it helps them very much with utilizing EXO. So as you will, experience different parts, different types of strokes that you might treat, this is one where she experiences a lot of neglect, impaired vision, muscle weakness, balance, all that can be assisted with that. Victoria's currently in first step. We are controlling the exoskeleton at this point.
Over here, not by the book anymore. I think we would start transferring you.
There you go. Remember what you said. You know this way, right?
I don't know if you can hear while she's walking, but you'll hear a little beep.
Mm-hmm.
That beep tells us when she's weight shifted properly. It will not let you take a step until you weight shift properly. So it's a little bit of biofeedback, auditory biofeedback.
It's strong, but it seems like it.
So in other words, we just don't put a patient in this robot and let them go for a ride. They have to act the whole time.
So we're going to forward, up, and we're just going to walk forward.
Doctor, you said at this phase, the exoskeleton is controlling the movement?
Yes, correct. We push a button and we advance the leg, but we make the patient be responsible for the weight shift. So we don't push the button until they shift their weight for that chime or that beep to go off. Correct.
And another question that we have from La Jolla is, what's the major difference between a physical therapy assistant and an occupational therapy assistant?
Well, from in reference to the Practice Acts, it's the difference would be that one major difference. I mean, I guess it's pretty obvious. The PTA functions underneath the direction of a physical therapist, and a CODA, or a Certified Occupational Therapy Assistant, operates underneath the supervision of an occupational therapist. Aside from that, in reference to treatments, they can pretty much do the same thing as a physical therapist can, and pretty much the PTAs can. Same thing for the CODAs. But the PT or the OT has to establish the plan of care, has to be involved in the goal setting, but the assistant takes an active role in communication by communicating, collaborating with their supervising PT or supervising OT of what they see in their sessions. And that gives the PT or the OT, information of updating a goal, changing the plan of care, and things of that nature. But as far as once the plan of care is set, the assistants can modify the plan of care, as much as they can or they feel comfortable with. But also, depending on the supervising PT or supervising OT, they have to feel comfortable with what the assistant's capabilities are. And so not only is it important to find a good mentor for you as an assistant, but also a good mentor from a supervising therapist as well, because they will help you develop into a good therapist in the future.
Dr. Our time is up, but thank you so much for your time this morning, and also for being able to share a little bit of your world with the students. We our partners at South Texas College, Mr. Miller, and our partners at Doctors Hospital for showing us and letting us be a part of your world for this 1 hour. Please note that we have this session recorded for the school district, so we will be sending out the links. And if anybody missed anything, we will have it uploaded and sent to you. We want to thank everybody who joined us today. And I don't know about you, but I had a great 1 hour and I learned a lot regarding this profession. I want to personally thank everybody that participated, and I wish you a very, very happy Friday. Thank you so much.
My pleasure. Thank you.
Thank you.